I'm going to speak about boring stuff, unfortunately, and this is clinical evidence regarding the Myval platform. Indeed, the Myval THV has been designed for precision in outcomes, as the company says, and I think that's quite accurate. This is the first generation with external skirt with two rows of metal cells covered by the fabric, internal and external skirt, and the open cells at the aortic end with bovine pericardial leaflets, standard anticalcification treatment. But there are two special things about this valve. The first thing is that it comes in many, many sizes. So intermediate sizes has been very important in theory because it's the closest thing you can get to customizing the fit of the valve to the patient's anatomy. And second, it comes in extra large sizes, like 30.5, 32, and I know the company is preparing a 33.5 and 35. The second thing is that the valve is pre-mounted on the balloon. So the valve is being introduced after being assembled on the table, like it is as one piece, and the crimped valve is actually stopped proximal distally on the balloon by the two stoppers, the proximal and the distal stopper. And we have shown in many, many cases that this crimping is actually very, very effective, and the valve stays on the balloon even after a lot of friction, tortuosity, acute bends, etc., etc. The third thing is that it goes through one sheath. So there's one single 14 French dilatable, expandable sheath that can accommodate all the sizes from number 20 to 32. And that is quite significant when it comes to vascular access and compatibility. This is the size chart. You can see the intermediate sizes, and there's always an overlap between the sizes when it comes to area. But the most important thing is that allowing for 5 to 7% oversizing, you can really customize. And the most important thing is that you choose the size that you think it's appropriate for the patient. You expand it nominally. You don't have to go +2 or -2 cc's of contrast on the balloon. And that means that you expand the valve frame to the nominal, which is predicted by the industry and by this flow chart. Of course, there is evolution of the platform. There is the octa-core, the octa-pro, and the octa-pro plus. So the main change in the design is the philosophy that now we have two octagon cells, one proximal covered by the fabrics, one distal uncovered. And the rationale is it's a 50-50% configuration. The rationale is when you inflate the valve, it doesn't foreshorten as much. This is the least foreshortening you get to any commercially available valve, at least balloon expandable valve right now in the market. And that is as close to predicting, like a stent in the coronaries, the positioning of the valve. Now, when it comes to evidence, there are two major randomized trials. The one is the Landor trial that, even Greece had two centers participating in Hippocrates and ourselves. And you can see the participations here. We were among the top 10 recruiters. The 30-day results were published in Lancet. And basically, it shows non-inferiority between the Myval THV series and the contemporary valves. This was one-to-one randomization between Myval and contemporary valves, the contemporary valves being Sapien platform, Evolute platform, and they were one-to-one in their respective arm. So you can see in all outcomes when it comes to freedom from all-cause mortality, stroke, procedural valve-related hospitalization, there was non-inferiority between the two platforms. Other indices was clinically infected, composite all-cause mortality, all stroke, quality of life outcomes, hospitalizations up to 1 year, hospitalizations, heart failure-related hospitalizations, and some insight at 1 year between the two platforms in terms of structural valve deterioration that follows on your previous conversation. That was 11% Myval THV, the contemporary valves had 13%. So non-negligible numbers, but still no different between the two platforms. So it's there. The SVD is there, whether it's primary thrombosis or early degeneration. But luckily, the clinical bioprosthetic valve failure was extremely rare in both arms. And you can see it was almost 0% in Myval and 1.4% in the contemporary valves. Again, the clinical efficacy with quality of life outcomes was again non-inferior between the two platforms. That was the first of the two randomized trials that compared TAVI. That was a Danish trial. Lots of patients, over 1,000 patients randomized between Myval and Sapien. So that's head-to-head comparison between the two balloon expandable platforms. You can see that 3.7% was valve-by-valve patients, bicuspid was 6.6%, so non-negligible, but most of the remaining patients, up to 90%, were tricuspid patients, pretty much all-comer trial. And you can see that at 3 years with VARC3 criteria, again, there was no inferiority between the Sapien 3 and the Myval THV when it comes to all-cause death, stroke, moderate severe AR, and moderate severe hemodynamic THV deterioration, SVD. Again, that shows that the platform is robust, and 3 years outcomes at this 1,000 patient cohort, randomized cohort, shows that this valve actually has durable results, at least at 3 years. There were some interesting subgroup analysis between the two trials, especially the 1-year hemodynamic analysis, that shows that when it comes to various sizes, there was pretty much some difference in the hemodynamic performance between the two platforms. Obviously, the mean orifice area was superior because of the supraannular platform in this mixed cohort. And clearly, you can see that when it comes to Evolute supraannular valve, the performance is better. But when it comes to PVL, the contemporary THV series, as dragged by the PVL from the supraannular Evolute platform, had worse PVL compared to the Myval THV series. But generally, the hemodynamic performance has been very good. What about small annuli? We have a lot of discussion about the small annuli, and there were, because this was an all-comer cohort to the landmark trial, there was a significant number of patients, mostly women, that had small annuli, as defined by an area of less than 430 square millimeters. So most of these patients have been elderly and female with a small annuli. They have been, most of them, low and intermediate risk patients. The clinical efficacy was no different, so death, stroke, and hospitalization between the two arms of the trial. But there was some separate analysis between the three platforms at 30 days that shows what, when we compared Myval versus Sapien, the effective orifice area was superior, significantly superior, 2 versus 1.8 in this small annuli, because of the suturing of the Myval THV had a superior orifice area to the Sapien 3 series, but of course inferior to the supraannular valve, 2 versus 2.3. But the prosthetic valve regurgitation that was similar between the two balloon expandable platforms, as discussed previously, similar to the mean pressure gradients. Myval balloon expandable valve had intermediate gradients between the Sapien platform and the Evolute platform, and that has to do with the superior effective orifice area that was discussed before. Generally, these observations, however, do not affect the clinical outcomes between the two arms. Similarly, to the outcomes in women are quite important. So the landmark subgroup analysis separated the patients that were female, and you can see that there was a significant number of female patients in the trial, 183 in the Myval cohort, and almost evenly split between the other two valves, 84 and 88. Again, 49% of the intermediate sizes were implanted in the female patients. The same pattern, half of the valves implanted were intermediate sizes for the whole cohort. That was the women as well. And again, more than 50% of the female patients recruited in the trial had small annulus area. That was expected. And again, you can see no difference between the two platforms the two arms of the trial, the three platforms, when it comes to all the outcomes that were discussed before. It is very interesting that generally, if you do some subgroup analysis between female and male patients, most of the outcomes favor women in the study cohort. This is different compared to the coronary intervention that we see usually female fare worse. But here, the female patients fare better in terms of mortality, clinically efficacy endpoint, the mixed endpoint, and procedural-related hospitalizations. So these are the results that were shown, and the clinical efficacy at 1 year was comparable between Myval THV, 9.5%, the contemporary 9.8%, and these results are in keeping with other women trials, SMART trial and the RIA trial. And there was a meta-analysis pulling the two randomized trials. I think that's quite important because this is a mixed cohort of over 1,500 patients. Again, you can see the demographic analysis between the two groups. And again, there was no difference between the two platforms, SAPIEN and Myval THV, in all the primary endpoints. You can see the 1 year mortality. The effective orifice area again was superior to Myval compared to SAPIEN. That is consistent no matter how you look at it. What is interesting was the pacemaker. There was no difference between the pacemaker between the Myval and the SAPIEN in this pooled analysis, but the Myval octa-core, the first generation, had a higher pacemaker rate in the compared TAVI cohort, and that was attributed to many factors. One of them could be the external skirt, but I think this is fixed in the new generation. So overall, we see now a wealth of evidence of randomized data comparing Myval THV to other platforms. Clearly, Myval THV is a versatile platform that comes in large sizes and intermediate sizes, allowing for custom fit to the native annulus. The data is good quality, is randomized clinical data. And we do need this data because, as we have seen from other platforms, it is not guaranteed that any of the commercially available valves can be in a randomized fashion compared with contemporary valves that have been around for some time and have guaranteed good quality outcomes. And we've seen that and we've learned that the hard way from other platforms. So it is important that we have this good quality data on the Myval series. The sub-study showed sustained benefit in various subgroup of patients. It is important to quote the superior hemodynamic performance of the platform compared to the other balloon expandable valve. And of course, we have new randomized data that are accumulating. There is a randomized baseline trial that compares the two platforms, balloon Myval and supraannular self-expanding valve to the valve-in-valve series. I know Giannis Iakovou and Onassis Heart Center participate in the trial, and there's a new bicuspid aortic valve investigator-initiated. Andreas Rook from Karolinska will start this trial soon, and that will be very, very important to look into this evidence. Thank you very much for your attention. I'm going to skip the cases because we don't have time, and I'm available for comments.
Yeah, terrific. And we just saw a previous case, great case anyhow, with this technology. So that's great.
So, Vlad, congratulations for the presentations. As always, excellent. Can you share some tips and tricks? How do you utilize the intermediate sizes in order to balance, the good sealing and also patient prosthesis mismatch, especially when you go to smaller annuli?
So basically, we follow the CT derived parameters. Of course, you always have to be mindful of, for example, the amount of calcium on the valve, the presence of LVOT calcification, the eccentricity of the valve. But generally, a rule of thumb is we go for the perimeter derived diameter of the valve, and we upsize to the next size, whether that's an absolute size or an intermediate size, it doesn't matter. We go nominally, we inflate. We have low threshold of predilating. I think that's a very important thing. This is something that we developed over the years. maybe coming from the self-expanding experience with the previous valve, the Accurate Neo 2, that was very sensitive in under expansion. But I really think you can avoid double tap, especially in patients with a lot of calcification. You usually finish very fast with minimal contrast, because once you get your pigtail in the right position in the non-coronary, you don't even need to inject any contrast. You pre-dilate, you put your valve, and you finish with one or two shots, and that's it. It's a very versatile, very flexible, very easy to use platform, and we have great outcomes.
Do you have any specific information regarding radial strength and as compared to the Edwards platform? We were talking about the bicuspid, as you said before. This is something that you should go for, or it's something worth investigating?
I'm not aware of any engineering information, to be honest with you. I always feel humbled by the engineers' information when it comes to radial strength. What I do know is that the foreshortening is definitely minimal, especially with the newest platforms. When it comes to bicuspid, for us, this is the first choice. So when we have a bicuspid anatomy, most of the time we use balloon expandable valve, and Myval has been our first choice for a few years now. But of course, bicuspid is a different animal. Sometimes you have to downside, you have to go higher. You have to account for the amount of calcification, whether it's in the raphe, what's the distribution. You have to aggressively pre-dilate to prepare the lesion, and double tap. You have low threshold, like post-dilatation with the same balloon. But generally speaking, it's a great platform to use for bicuspids.
I think pre-dilatation is very, very important.
100%.
Yep.
Oh, Vlasis, congratulations. One quick question. So we have seen that there is a shift from moving from three-cusp view to cusp overlap, even for the balloon expandable valves. Have you seen, I know that in Onasio they do it, we have started in the Naval Hospital. Have you shifted your care, your delivering of the valve in this way, and have you seen better results in this way?
Absolutely. You can minimize foreshortening in the LVOT. So our practice, we use contralateral radial size 5 French pigtail catheter. We put it at the bottom of the non-coronary cusp. We cross the valve in the three-cusp view, but that's a personal preference. You can cross it in any view. If we have bicuspid, we usually go to the cusp overlap view. It's easier to cross. And then we don't even inject. We pre-dilate with the balloon that we chose. Sometimes we don't pre-dilate if there's minimal calcium, but most of the times we pre-dilate. Again, no contrast, and then we go in with the valve. The first injection we use is when the valve is in position, because we want to make sure that the pigtail is actually at the nadir, at the level 0 of the non-coronary cusp. Again, cusp overlap view, very high implantation, 90-10, 90 aortic 10 LVOT, and we're done. And this is very, very, very predictable. In fact, this ultra low contrast, we've got a paper in press. Hopefully, we will publish it in the next month or so to show that this is feasible. And using cusp overlap view is paramount on this. It is a very stable and very predictable view to implant your valve.
Okay, good. I think we have to leave it there. Thank you so much, Vlasi.
Thank
It's
you.
always a pleasure.